So a few days before I left New Delhi for Kampala via Addis Ababa, I opened Twitter, which is of course my favorite source of news these days. I don't read the newspapers anymore. I go to Twitter and follow the people who are interested in the same areas that I am. And I saw this item in a town in Uttar Pradesh. This is an incident that happened in a town in a northern state, our most populated and one of our poorest states in Uttar Pradesh. So this is what happened in one night. At least 30 children died in 48 hours in Gorakhpur's BRD Medical College amid allegations that a private contractor stopped supplying oxygen cylinders over a payment dispute. More details started to emerge. It's the rainy season in Uttar Pradesh, much of North India. And every year we see an epidemic of Japanese encephalitis, a deadly vector-borne disease. However, this scale of deaths in one night was unprecedented. A number of terrible personal stories began to emerge from this issue. And what was surprising was that at the same time as many of these personal accounts began to emerge of dead children and the travails that the families had to endure, we saw that the government was actually denying the occurrence of this incident altogether. So what is behind this incident? The surface issue here is delay in payment to a private vendor supplying an essential and continuous service. But what actually led to this? So I went and I opened some websites and I looked at the story. And this is just one of several different and competing accounts of this incident that are emerging. What's clear is that there was a chain of potential obstacles involved, and these related to a number of different things. And you can read these accounts more closely, but they all relate to delays in financial allocation on planned budgets, which is a major issue. Simple things like banking transaction delays, administrative overload. In one case, the doctor blamed the visit of the chief minister to the hospital for the delay in sanctioning the funds. And of course, delays in releasing funds from the treasury. The other important context for this issue is Japanese encephalitis, a disease for which many of the children were hospitalized. It strikes every year and it kills hundreds of children. But still, our preparedness has not necessarily improved, and broadly, investments tend to focus on healthcare rather than on prevention. So this is the graph for incidence, and this is for deaths. So you can see it's gradually increasing over the last 5 years. We don't have the data for the last 2 years. So over the next few days, I read several news articles about this tragedy, each presenting a different view on the problem. But when I opened the Twitter the next day, these two news items caught my eye. The first was an article about Microsoft, unrelated to the tragedy, about an innovation to remind TB patients to take their medicines. The second was a policy pronouncement from a senior federal minister shortly after the tragedy. It's a message that hints towards public-private partnerships for health services on a large scale, which is often proposed as a solution to inefficiencies in government services. So what struck me when I saw these two items is that both of these are packages or products which sometimes seem like simple and obvious solutions which we need to implement. These products, packages, and service delivery solutions, they're important, and we need to keep them coming. But I couldn't help but think, as I read these articles after being immersed in the tragedy in Uttar Pradesh, we keep coming up with solutions, but what lets us down is governance. Piped oxygen supply, which the children had in those hospitals, is also a great product. But we couldn't ensure maintenance of payments for a single vendor to provide it. Public-private partnerships for entire health services could definitely also face similar issues. So what I'm saying is not rocket science. It's known and felt by everybody, common people most of all. You often hear the phrase, it's a system that needs to be put into place. There's no system there. Others say it's governance, the will and the decisions that improves those systems and their performance. Each of these words is loaded and carries many connotations and meanings. But I'm going to focus on the governance of health systems for the rest of this talk. This is just a quick overview of how I structured the talk. First, I'm going to try and clarify what is this thing, what is this beast that we call governance, and what are the weaknesses that we commonly find in low and middle income countries. Next, I'll outline two specific phenomena of importance when it comes to health systems governance in low and middle income countries: institutional capture and parallel systems. So these might sound like mouthfuls, but I'll try and explain them as we move ahead, and I think they are really quite obvious. These emerge partly from reading of the literature, but also from my research in the last 10 years, mainly in India, but also in other Asian and African contexts. I believe these to be important to recognize and understand if we're to improve health systems governance. And finally, reflecting on these phenomena, I'll close with some thoughts on how to strengthen governance for universal health coverage, and also some pitfalls to avoid. I also had a couple of nagging questions around investing in governance, and since I'm not an expert in financing, I'm hoping that you and the panelists, the eminent panelists to follow, can help me to get some answers to those questions. To start with, we all know that health governance is a problem in many low and middle income countries. The story I described was only one of its symptoms. Other symptoms are subtler and deeper and have even more wide-ranging impacts. Governance is a funny thing. We don't always know what does make it work, but we definitely know when it doesn't work. I believe that if we are to tackle problems of governance, we need to get more scientific. And we need to find out what are the specific failures and what are their causes. So here are a couple of definitions from the World Health Organization. One is specific to health systems, and there's one broader definition. Here's another definition from DFID. What's clear, though, is that governance is a process, and it refers to both the formal as well as the informal rules that shape society. I think we often have an implicit understanding of what makes good governance, but we are not often able to articulate it. And these normative definitions or normative positions on good governance are useful in helping us think about what constitutes good governance. So you'll see that accountability, capacity for policy making and implementation, participation, responsiveness, fairness, these are some of the things that we look for. Reflecting on some of the research and experience of health systems in low and middle income countries, there are 5 areas where we see major weaknesses in health systems governance in low and middle income countries. Let me just talk you through some of them. The first is the constitutive element, the written laws, rules, and policies. Does a country have a stated commitment to increasing or to universalizing coverage? Is it backed up by legal entitlements where possible? Are there laws and rules to empower the state to ensure effective services, either directly or in partnership with the private sector? The second challenge is capacity. And this is very poorly understood, but extremely important when it comes to institutions of governance. Many low and middle income countries simply don't have enough personnel to populate and run the institutions that enact policy, design systems, manage stakeholders, or regulate standards and safety. In other cases, the technical capacities are lacking. The governance capacity of ministries of health is the first theme that will be addressed by the new WHO Health Systems Governance Collaborative. And this is a small slide that shows what the Governance Collaborative is. I'm afraid the text is very small, but I'd be happy to refer anybody who's interested to the website and this process. It's a process in which anybody is invited to join if you're interested in health systems governance. The third challenge is coordination. From my experience, there's almost always ambivalence, conflict, and poor communication between different stakeholders, between different departments and institutions around the division of roles and responsibilities. Important tasks often fall between stools, and in some cases there is unnecessary duplication and overlap. The fourth weakness is institutional capture by private interests. And this goes beyond what we commonly refer to as corruption. We'll be discussing that in a little bit more detail. The fifth, and in my opinion the greatest challenge, is accountability to and empowerment of communities. I say this is the greatest since many of us in low and middle income countries, we come from very unequal societies. And we find that in instances where communities actually do find their voice, governance can improve fast and dramatically. Each of these governance challenges is considerable and needs to be tackled as part of the natural process of social development. We don't have time to analyze all these aspects of governance, but I'd like to describe two phenomena which I believe to be of particular importance in low and middle income countries. The first is institutional capture. This is a well-recognized issue, well-defined in the world of public policy. But to understand institutional capture, specifically in health systems, it's helpful to take a step back and look at how health systems tend to be configured in low and middle income countries. Many health systems in Asia and increasingly in Africa have what we call mixed health systems. Here's a definition from Oxfam. Sania Nishta's definition takes it a step further and identifies that the public-private mix can often become a syndrome. So mixed health system syndrome is not just the coexistence of public and private, which we see everywhere. It refers to a particular type of intermixing or intermingling of public and private institutions, coupled with the weakening of public institutions, which has adverse consequences for equity and quality. For example, we saw in the film earlier, the informal payments in the public sector, or the fact that the patients have to pay for supplies and medicines when they visit public facilities that are supposed to be free. There are some other symptoms of this syndrome which are described over here, which we will all be familiar with from our respective contexts. So the point I'm making here is that the culture and prevalence of this intermingling of the public and private space, the culture and prevalence of private behavior in public institutions is also mirrored when it comes to governance. A classic example of this is regulatory failure. So our research on government health regulatory organizations and the behavior of people working in these regulatory organizations in India shows that they are conditioned by weak capacity, poor design, and heavy lobbying from private interests. And ultimately, the incentives within which these people work are not conducive for them to do their job of regulating private healthcare facilities. And this is an explanation for why regulation fails. The other phenomenon that I'd like to highlight is parallel systems. So what do I mean by parallel systems? These are informal or semi-formal decisions and behaviors in public institutions that exist side by side and intersect with formal rules and norms. And they are also often driven by private interests and operate through social or political networks. Parallel systems are often hidden because they represent a pattern of behavior that is different from the written or constitutive aspects of policy. And here's an example of a parallel system: health worker posting and transfer. We all know that government health workers want to be posted in areas where they have an easier life, better schools, and better opportunities for private earnings, whether they are authorized or not. These postings and transfers often take place through informal financial arrangements that serve the needs of specific actors. But ultimately, this is not always in the broader public benefit. And this is one of the reasons that lead to the maldistribution of the health workforce between areas where they're already oversupplied and other areas where they're actually needed most, but there's an undersupply. So coming back to those 5 challenges of governance that we see, parallel systems often operate covertly, and they often favor the capture of health systems by specific groups of people who have the necessary influence. So it's not that the system doesn't work. In fact, it actually does work. But it is a sort of an equilibrium that favors some and not most. People in the system are not bad people. They do what they can. I'm one of those people. And they're often well-meaning and self-serving at the same time, as we all are. However, ultimately, the system doesn't do its full stated job of ensuring access, quality, and equity to healthcare, which is what universal health coverage is all about. So from this lens, if we look at what happened in Uttar Pradesh, the story that I recounted in the first few slides, the failure of the parallel system in Uttar Pradesh with the oxygen supply deaths was not that the children died. Actually, poor children die there every year, as we have seen in in the graph. But they usually die 5 at a time or 3 at a time. And there's not a huge outcry. The failure in this instance of the parallel system is that it got out of hand and many children died in one night, and that attracted attention to the issue. What is important to note here is that the other governance challenges, capacity, lack of rules and laws, lack of coordination, and failure to empower the community, they benefit and perpetuate the hidden parallel system that is benefiting a few and not the many. So if that sounds like a very gloomy picture, sometimes it is, but I don't think that's the whole story. I think there is a lot that can be done to improve governance. Governance problems can be tackled, contrary to what we think, and they require investments. Let's think about some of the ways that we can invest for better governance. When sometimes it seems that entrenched interests are very hard to dislodge, and they indeed are, it's critical to remember that the other interventions can break this cycle of institutional capture. We can work on strengthening laws and rules. We can give communities a voice. We can build organizational and personnel capacity. And there are many examples of improvements coming about through such reforms, which I'll be happy to share during the panel discussion. Better governance and institutions are fundamental for development. All policies are contingent on better governance. And hence we have no choice in our low and middle income countries. We have to invest in governance. It's key to avoid in this process what I call the evidence of effectiveness trap when it comes to supporting stronger institutions. Governance is complex and socially constructed, and in each context, there's a different pathway to better governance. We tend to work with principles rather than with specific predefined pathways. And it's not something that lends itself to standard metrics of evaluation, particularly the sort that we're used to in the public health world. And for the same reason, the so-called evidence base is actually quite weak. We don't have a lot of quantitative evidence to support which are the good governance practices that lead to better health outcomes. And more research is definitely needed, but sometimes this calls for focused policy and institutional analysis, and not necessarily more randomized controlled trials at great expense. In low and middle income countries, particularly, nurturing new leadership is absolutely key. We need schemes to retain intellectual capital in our countries, and we need to develop robust, accountable institutions at all levels, right from the ministry down to the community. Ultimately, it's also important to keep in mind that governance reform is very hard, because it's about looking at our own actions as influencers and decision makers. Before I close, I just wanted to highlight the words of this man, who's pointed out that our systems are often focused on rules and norms to be obeyed, rather than on people actually getting what they need in the real world. So if we do want a just system, a just health system, and better governance, we need to redesign it to shape and respond to people's lives, rather than looking for ideals from elsewhere. We can certainly learn from other contexts, but simply translocating or transplanting solutions from other contexts is not always what works. And to conclude, I have a couple of questions for all of the experts on health financing in the room, in which I don't count myself. How should governments in low and middle income countries balance external versus domestic investments in strengthening health systems governance? And second, when it comes to strengthening financial governance in the health sector, the concerns go beyond mere financial corruption and also include a broader form of corruption, which is institutional capture. What should be the priority actions to tackle these from a financing standpoint? Thank you very much, and I hope you enjoy the rest of the 3 days of this excellent conference. I'll leave you with some Twitter accounts to follow if you're more interested to learn about health systems and governance. Thank you.